Hello everyone. Today we are going to start our series on cornea. The first lecture is on bacterial keratitis. The purpose of today's lecture is to have a proper understanding of bacterial keratitis and a brief overview of the anatomy of cornea. As far as bacterial corneal ulcer is concerned, it is one of the major topics for exam as well as a very important topic for clinical ophthalmology. It's a must-know in ophthalmology. Beginning with the anatomy and physiology of cornea. So what you see here is the front portion of the eyeball, and here is the cornea, a transparent cornea and sclera. This junction, that is the corneoscleral junction, is known as the limbus. If you see from front, what you see cornea as a structure which is almost round, but actually it is horizontally elliptical or it's a horizontal ovoid in which the horizontal diameter is more than the vertical diameter. So horizontally it will be about 12 mm, ranging from 11 to 13 mm, and vertically the average is about 11.5 mm, ranging from 10 to 12 mm. The thickness of the cornea varies from the center to the periphery. The center being the thinnest portion, here the central corneal thickness is given as 540 microns, and as you go to the periphery, the cornea thickens. As you go to the periphery, the cornea thickens. And it is a transparent structure because there are no blood vessels, there are no lymphatics. The nerve supply, the nutrients, if there are no blood supply, the nutrients, where are the nutrients coming from? The nutrients are coming from three sources. One is the aqueous, one is the tear film, and the third are the limbal arteries or the limbal vessels surrounding the cornea. So usually the aqueous is the main source for glucose and the tear film is the main source for oxygen supply. Coming to the nerve supply of the cornea, it is the most densely innervated tissue in the body and is supplied by the first division of the trigeminal nerve. Now the histopathology of cornea. What you see here are the different layers of cornea. It's a section of cornea from anterior to posterior. Begins with the superficial portion is the epithelium. Then comes the Bowman's layer. Below the Bowman's layer is the stroma. It's 90% of the cornea is formed by the stroma. Then the Descemet's membrane and below the endothelium. So endothelium is the innermost part of the cornea. If you see the epithelium here, what you see here, it's a basal lamina. On the basal lamina, there are stratified squamous epithelium. Sitting on the basal layer is the basal cells. Basal cells, as they go superficially, they becomes wing-shaped cells, and then the superficial cells. These superficial cells have this microvilli. To see here is the microvilli. On this microvilli is attached the tear film. So the microvilli increases the surface area of the epithelial cells so that the epithelial cells oxygen supply is maintained. And this is very important to maintain a healthy corneal surface. Below the epithelium is the stroma, and in between the stroma and the epithelium is the Bowman's layer. At the Bowman's layer, it's an acellular superficial layer of stroma formed from the collagen fibers. Stroma forms 90% of the corneal thickness. It is formed by regularly arranged collagen fibrils. And these fibrils are arranged such that there is no diffraction of or no irregularity, and the light passes through these collagen fibrils smoothly. These collagen fibrils are laid down by the fibroblasts. Fibroblasts are known as keratocytes. These are the collagen secreting cells of the stroma. And this stroma cannot regenerate after it has been damaged. Below the stroma is a Descemet's membrane. Descemet's membrane is a lattice work of collagen fibril and it has got a regenerative potential. The Descemet's membrane is lined by the endothelium, and it's a monolayer of polygonal cells. Number of the cells decreases with age. That is, the endothelium have a fixed number of cells at birth, and as the child grows up or as the age increases, the number of endothelial cells decreases. Now coming to the main topic, that is bacterial keratitis. So what do you mean by keratitis? So any inflammation of the cornea is known as keratitis. Bacterial keratitis, so keratitis could be of many forms. The causes could be bacterial, it could be viral, it could be fungal. So it is named as bacterial keratitis, viral keratitis, or fungal keratitis. So these are infectious keratitis. Then there could be inflammation, then because of certain reasons. So depending upon this, the inflammation of cornea is known as keratitis. So bacterial keratitis is caused by bacteria. Most important are Staphylococcus aureus and Streptococci. These are usual commensals of the around the eye, and because of certain damage in the eye, it causes bacterial keratitis. Usually when the immune status of the cornea decreases, like in case of diabetes mellitus or immunocompromised patients, or a patient with contact lenses, like in patient with contact lenses, the usual cause is Pseudomonas because of the contact lens causing small abrasions. This bacteria gets lodged into these abrasions and forms keratitis. In contact lens cases, there is one more thing, that because of contact lens, the tear film is not spread evenly over the epithelium, because of which there is hypoxia of the epithelial cells. That also adds to the formation of keratitis or bacterial keratitis in cases of contact lens wearers. Staphylococcus aureus, it's a gram-positive cocci producing well-defined white or yellow-white infiltrate, and Streptococcus, it's again a gram-positive cocci causing aggressive infections. Risk factors are contact lens wear causing corneal epithelial erosions, small hypoxia, and minor trauma. Minor trauma causing erosions. Trauma because of any external trauma, like rubbing off, even rubbing off eyelids. Ocular surface diseases like herpetic keratitis. In herpetic keratitis, what happens is that the nerve cells on the cornea gets damaged, and because of decreased sensation, there are increased chances of infections. In dry eye, again, it predisposes to corneal ulcerations. Blepharitis means inflammation of the eyelid. Entropion, again, a problem of the eyelid, which causes abrasions or trauma to the cornea and further bacterial infections. Other immunocompromised states like diabetes, vitamin A deficiency, all of this are predisposing factors for corneal ulcerations. Now coming to the clinical features, we begin with the symptoms. The symptoms are pain, redness, blurred vision, discharge, and tearing or increased watering from the eyes. Signs, I can show you what these signs are. So these signs are epithelial defect, stromal edema, anterior uveitis and hypopyon, eyelid and conjunctival swelling, perforation in severe cases, especially in Pseudomonas, endophthalmitis, scarring, vascularization or opacification are the sequelae of the bacterial keratitis. So here I will show you what the signs are. Here there is a little bit of lid edema there. Then conjunctival congestion, more around the cornea here. What you see here, more around the cornea, conjunctival congestion. So this area surrounding the cornea, more congestion here compared to this area here. So this is known as circumcorneal congestion. And then what you see here is a edge here. This is the edge of the corneal ulcer, and here is a yellowish discoloration here. This yellow discoloration is because of the fluorescein stain. Here what you see is the yellow discoloration. So whenever there is an epithelial defect, if that epithelial defect you stain with fluorescein, it's a dye. So put that dye on the fluorescein strip, strip of white paper. When it is stained with fluorescein and then touched on this corneal surface, the corneal abraded surface takes up this stain and it becomes a green color. That gives you the area of the corneal ulceration or area of the epithelial defect. It demarcates the epithelial defect from the rest of the cornea. So here is the fluorescein stain which demarcates the corneal ulcer, position of the corneal ulcer. The hazy cornea around here, again a sign of corneal ulcer, hazy cornea. Then we have the stromal infiltrates here, and this is the hypopyon. What you see here is the hypopyon. Hypopyon is pus in the anterior chamber. The anterior chamber, through the almost translucent cornea, you can see the anterior chamber, the content of the anterior chamber. So here is the pus in the anterior chamber, that is the hypopyon. So here we have the hypopyon. Hypopyon here. And what else can you see here? These are the leading edges here. So this is a case of progressive. If you try to stage the corneal ulceration, this is the progressive stage of the corneal ulceration where there is a where the edges are rolled over, and here we see the maximum amount of organism are also seen in these leading edges and at the base of the corneal ulcer. So this is a progressive stage. Next comes the healing stage, when the size of the ulcer epithelial defect, it decreases, the corneal transparency increases, the corneal edema decreases. That is the healing stage. The third is the cicatricial stage, that is when the healing has completed and there is scar formation, that is a cicatricial stage of the corneal ulcer. Now what could be suppose if you do not give any treatment at this stage, what will happen? If the corneal ulcer increases or the epithelial defect increases, it may then continue into the stroma, full thickness of the stroma, and it reaches the Descemet's membrane. When it reaches the Descemet's membrane, because of the increase in intraocular pressure, it tries to come out. Descemet membrane peeks out through this defect in the cornea and forms a descemetocele. This could be one of the complications of corneal ulcer. If the descemetocele is not able to maintain the integrity of the eyeball, sometimes it also ruptures and causes perforation of the cornea. Now coming to the investigation in case of bacterial keratitis. So for any keratitis or any infection, what we have to do is to find which organism is responsible for the disease. So what we do is a corneal scraping. That means with a knife or a blade, we remove some material of the cornea, especially along the margins and the base of the lesion. This is scraped, and this is sent, the material is sent for gram stain, Giemsa stain, culture sensitivity, and for fungal examination. So here you have removed some portion of the cornea, scraped it and sent for bacteriological examination. And for culture sensitivity, so this is a blood agar. We use different nutrient medias. It's blood agar. This is Staphylococcus aureus growth in the blood agar, and then chocolate agar. Neisseria organisms, it goes very nicely on a chocolate agar. Then coming to the treatment of bacterial keratitis. The first important thing is the contact lenses. Contact lens is a very important risk factor for bacterial keratitis. You have to discontinue the contact lens. Not only discontinue the contact lens is also sent for microbiological examination, plus the case in which you have put the contact lens and the contact lens fluid. All these are sent for microbiological examination to identify the organism causing bacterial keratitis. The choice of drug is fluoroquinolones. In severe cases, we can use 2 fortified antibiotics, usually a cephalosporin and an amino glycoside, covering both gram-positive and gram-negative bacteria. Fortified antibiotic means a normal topical antibiotics is fortified with injectable antibiotics, like the gentamicin drops fortified with injectable gentamicin. Apart from topical antibiotic drops, we can also use subconjunctival antibiotics. It's only used in cases of poor compliances. So along with antibiotic drops, what we use is mydriatics like atropine, humide. This is used to prevent any posterior synechia and to reduce pain. Then next is the steroids. The use of steroids is controversial. Once the infection is controlled and we have seen that the ulcer is healing, then we can start on steroids because it will reduce inflammation and decrease pain and discomfort associated with inflammation. But then it has to be balanced because steroids will also delay healing. So there has to be a balance between the decrease in inflammation and the process of healing. It's usually not used until unless the inflammation exceeds infection. In only those cases, steroids can be used. Systemic antibiotics can be used in very severe cases of corneal ulcer, in cases there is a corneal thinning, or if there is scleral involvement, or the infection is because of Neisseria group of organisms or H. influenza. In these cases, you can use systemic antibiotics. To summarize, bacterial keratitis is a very sight-threatening process. Any corneal ulceration, stromal abscess formation, and surrounding corneal edema, anterior segment inflammation, all these are characteristics of the diseases, and it has long-standing effect on visual acuity. Now, what is the applied aspect of bacterial keratitis? It is one of the most important complications of contact lens use and refractive corneal surgery. Early diagnosis and treatment are key to minimizing any vision-threatening sequelae. In addition, close follow-up, attention to laboratory data, and changing antimicrobials if no clinical improvement is evident are important elements for successful outcome. What is the expected questions on bacterial keratitis? A very important question, and almost it's repeated most of the time. It is right, the pathogenesis, clinical features, stages, and management of bacterial keratitis. So in management of bacterial keratitis, you will have to write the investigations that are required for bacterial keratitis. So apart from the pathological investigations that we had mentioned here, we have to have some systemic investigations as well. Specifically, we have to rule out diabetes mellitus or any other immunocompromised state. And first, along with bacterial corneal ulcer, we have to treat that also for a complete healing. So these are the books we have compiled this presentation from. Thank you. And special thanks to the Med Department for the guidance and format validation. Thank you.